In terms of today's grand rounds, Pooja Prabhakar and Bruce Sangeorzan are going to talk about calcaneal fractures. I think it's important to note that we owe them a debt of gratitude for organizing this with 2.5 weeks notice because of a cancellation. So very much appreciated. And without further ado, I'll hand it over to you, Pooja.
All right, good morning, everyone. My name is Pooja Prabhakar. I'm a third-year orthopedic resident here at the University of Washington. It's my honor to be presenting grand rounds today with Dr. Sangeorzan. We'll be discussing calcaneus fractures, focusing on updates in management. I have no disclosures. I'll begin with an introduction to calcaneus fractures, followed by a review of the relevant anatomy, radiographic workup, and classification. I'll then go over treatment options and introduce relevant comparison studies. I'll then hand it off to Dr. Sangeorzan to further discuss the current management options, and finally, we'll both go over a couple of cases. Calcaneus fractures are the most common tarsal bone fracture, making up 75% of foot fractures and 1 to 2% of all fractures. While a quarter of calcaneus fractures are extra-articular, including avulsion fractures of the tuberosity, subtentaculum tali, or anterior process, 75% of them are intra-articular. The most common mechanism is a traumatic axial load, such as a fall from height or motor vehicle collision. The talus acts as a wedge, causing flattening, shortening, and widening of the calcaneus. Less than 10% are open injuries, and over 3/4 of these fractures are associated with other injuries, such as other foot and ankle fractures, like a contralateral calcaneus fracture, or vertebral fractures. The displaced intra-articular fractures are life-altering injuries. They're notorious for being difficult to treat, and there continue to be numerous controversies regarding their management. To briefly go over anatomy, there are 4 articular facets, 3 superior facets that articulate with the talus, posterior, middle, and anterior, and an anterior calcaneocuboid joint that is at the distal end of the anterior process. The posterior facet experiences significant increases in contact stress with progressive displacement of the posterior lateral fracture fragment, whereas the other 2 superior facets do not. And we also have the tuberosity, which is the insertion site of the Achilles tendon and the plantar fascia. The subtentaculum tali is on the medial side of the calcaneus, which gives support to the overlying talus, and is made up of dense bone that is ideal for fixation. It provides a groove for the flexor hallucis longus tendon that runs directly inferior. And this medial wall is close to neurovascular structures, the posterior tibial artery and tibial nerve. The subtentaculum tali is also known as the constant fragment in intra-articular fractures. That is, it has been thought that that fragment remains in its native position to the talus due to its attachment to the talocalcaneal spring and deltoid ligaments, thus being used as a scaffold to fix the other fragments too. However, multiple studies have shown that there is a high rate of subtentacular fractures that are displaced, ranging from 10 to 42% of all intra-articular calcaneus fractures. On the lateral side is the sinus tarsi, a tunnel between the talus and the calcaneus, and the lateral wall is flat, therefore used as a common site of anchoring. However, the overlying soft tissue laterally is quite thin. The vascular anatomy of the calcaneus is important to keep in mind, especially in regards to the surgical approach. The medial calcaneus is supplied by perforating branches of the posterior tibial artery, and the lateral calcaneus is supplied by the lateral calcaneal branch from the posterior tibial or perineal artery. There is a watershed area at the midline between the medial and lateral branches. And the sinus tarsi artery provides 10% of the total blood supply. The common surgical approaches are on the lateral side of the calcaneus. The angiosome pattern laterally shows that the perineal artery provides perfusion to the lateral flap of an extended lateral approach, and variations in the incision site can lead to flap ischemia. Moving on to imaging, other than your standard trauma workup, all calcaneus fractures should get 3 views of the foot and ankle, as well as bilateral Harris views of the calcaneus. The Harris projection is an axial heel radiograph tilted 45 degrees caudally with respect to the long axis of the foot. This view allows for evaluation of subtalar joint displacement, heel widening, and varus deformity. Obtaining the contralateral side can assist in preoperative planning. CT is part of standard workup for calcaneal fractures to assess fracture lines and displacement of the intra-articular fragments. On the lateral X-ray, there are 2 angles that can be used to determine the position of the posterior facet. The Bowler angle is measured by drawing 2 lines from the highest point of the anterior process to the highest point of the posterior facet, and from the highest point of the posterior facet through the highest point of the tuberosity. Normal angle is between 25 and 40 degrees, And in intra-articular fractures, the angle decreases as the posterior facet collapses inferiorly. The Gissane or critical angle is measured at the intersection of a line along the posterior facet and a line from the anterior process of the calcaneus down to the inferior posterior facet. A normal angle is between 120 and 145 degrees, and this angle may be increased or decreased with intra-articular fractures. Other measurements to consider on injury x-rays and when performing reduction are the calcaneal height, which usually decreases due to impaction, and the calcaneal width on Harris views, which usually increases. For intra-articular fractures, there are multiple classification systems, the two most common being the Essex-Lopresti and the Sanders classifications. The Essex-Lopresti classification is based on x-rays and uses the planes of the primary and secondary fracture lines in order to classify fracture patterns into joint depression or tongue type. The primary fracture line always occurs through the posterior facet, creating two fragments, anterior medial and posterior lateral. The secondary fracture line either occurs in the axial plane or behind the posterior facet. In a joint depression fracture, the secondary fracture line exits just behind the posterior facet. In a tongue type fracture, the secondary fracture line exits in the axial plane at the tuberosity. The tongue type fractures are associated with superior displacement of the tuberosity due to the pull of the Achilles tendon, which can cause skin tenting and pressure necrosis, requiring urgent operative management. The Sanders classification was published in 1993 in Core and based on the number and location of articular fragments seen on coronal and axial CT images. Type 1 fractures are non-displaced, irrespective of the number of fracture lines. Type 2 fractures involve one fracture line resulting in a two-part fracture. Type 3 fractures have three parts with centrally depressed articular fragment. And type 4 fractures are highly comminuted with at least 4 articular segments. Fracture lines are described as A through C from lateral to medial. And despite its widespread use, several studies have demonstrated poor reproducibility with inter-observer reliability ranging from 0.2 to 0.5 and inter-observer reliability from 0.3 to 0.5. Additionally, the pictures shown in the classification with both the middle and posterior facets in the same view cannot be seen in any real imaging views. Additionally, the study by Swords et al. Out of our department in 2014 that looked at 4 CT-based classification systems found that none of them were associated with outcomes when using the musculoskeletal functional assessment score. They found that only anterior process comminution and the surgeon's impression of severity were associated with outcomes. Treatment options for calcaneus fractures can be broadly grouped into non-operative and operative. Within operative options, there are percutaneous versus open, and with an open using an extensile lateral approach versus a sinus tarsi approach. A subtalar fusion with concurrent ORIF can also be performed as primary treatment for certain fractures. When intra-articular calcaneus fractures are not treated appropriately, either with non-operative treatment or poor surgical treatment, it can lead to arthritis and deformity. Potential outcomes include subtalar arthritis due to posterior facet comminution, subfibular impingement, which occurs from the lateral aspect of the calcaneus driven inferior to the fibula, which can also cause injury to the peroneal tendons, heel widening leading to poor shoe fit, and a horizontal talar attitude, as the talus assumes a more horizontal position on a flattened calcaneus, which can lead to anterior impingement of the distal tibia. Absolute indications for surgery for calcaneus fractures include dislocation at the ankle or subtalar joint, and open fracture or skin at risk. These are general indications for each treatment option, with closed management usually utilized for extra-articular Sanders 1 and some Sanders 2 and 3, ORIF for Sanders 2, 3, and 4, and subtalar fusion for comminuted fractures or as a salvage procedure. For intra-articular fractures, the pendulum has swung between non-operative and operative over the decades. 3 multi-center RCTs have compared non-operative versus operative treatment for intra-articular fractures, and all conclude that there was no difference in outcomes. The first, the Buckley study by the Canadian Orthopaedic Trauma Society in 2002, was the first of these large multi-center RCTs. They analyzed 309 patients with displaced intra-articular calcaneus fractures with 2 to 8 year follow-up. They excluded open fractures and those that were over 2 weeks old. They concluded that without group stratification, there was no difference in outcomes. However, subgroup analysis demonstrated statistically significant improvements in the SF36 scores with surgery in women, patients not receiving workers' compensation, younger patients, and patients with highly displaced fractures. They also found that patients managed non-operatively were 5.5 times more likely to require secondary subtalar arthrodesis. Some limitations were that 76% of the surgeries in this multi-center study were performed by a single surgeon, and that the VAS and SF36 scores are not validated for calcaneus fractures. This Swedish study in 2013 with an 8 to 12-year follow-up found no difference in outcomes at 1 year or final follow-up. However, the data trended toward improved outcomes with the surgical management at final follow-up. The study had an increased proportion of residual subtalar displacement in the operative group compared to other studies, which may explain the study's failure to reach statistical significance. They found that in the surgical group, radiographically evident subtalar arthritis was reduced by 41%, but they also had a higher rate of complications. The outcome measures used are also a limitation for this study, as the AOFAS score has been noted to be highly biased and imprecise. The latest multicenter RCT, the UK HEAL trial, was published in the British Medical Journal in 2014 and evaluated 2-year outcomes of 143 patients and found no difference at 2 years in the Kerr-Atkins functional score, SF36 score, AOFAS score, and gait measurements. Even in their subgroup analysis, there was no difference for Sanders type 2, 3, or 4 fractures. The surgical group had a high complication rate at 17%, mostly infections. One criticism of the study is the selection bias. Over 2,000 patients were screened, but only 151 consented to be randomized. And they excluded over 50 fractures with fibular impingement and significant deformity that required reduction. Another criticism of the study was that they had a very short follow-up of only 2 years. This year, the group published an update with longer-term follow-up, 5 years and almost 80% of the patients. And there was no clinical follow-up. They used a written questionnaire assessing the Kerr-Atkins scores, and they again found no difference in those scores. They did find that the operative group had significantly higher rate of additional surgery compared to the non-operative group. Moving on to the various surgical approaches, the 3 broad categories are percutaneous, sinus tarsi, and extensile lateral. The extensile lateral approach has been associated with high risk of wound complications, which has resulted in a push towards smaller incisions. Many studies have looked into whether these less invasive approaches offer similar outcomes and improved complication rates. A retrospective study published in 2019 comparing percutaneous versus the open extensile lateral technique found no difference in complication rates. Fractures that were open, 2-part, or in smokers were more often treated percutaneously. In the open group, they noted a significantly higher rate of restoration of Bowler's angle at 100%, as well as a significantly higher rate of anatomic reduction compared to the percutaneous group. Another retrospective study compared a minimally invasive sinus tarsi approach to the extensile lateral approach and found no difference in radiographic angles or in clinical outcomes. But they did find that there was more wound complications and secondary surgeries with the extensile lateral approach. Finally, subtalar fusion is an option for primary treatment of some fractures, generally those that are comminuted or have severe cartilage loss. This RCT out of Canada was published in 2014, comparing RAF versus RAF plus subtalar fusion in Sanders 4 calcaneus fractures. At 2-year follow-up, they found no difference in outcomes, although at 31 patients, the study was underpowered. These are my references, and I'll hand it off to Dr. Sangeorzan to continue from here.
Okay, so that was a very nice summary of the last 45 years of calcaneus fracture management. So we have to ask ourselves, with 3 prospective randomized trials, why are we talking about open treatment of a calcaneus, since all 3 trials failed to show a difference or an impact from open treatment? All those trials are a little bit incomplete, so there are some areas where open treatment still makes sense, and one is avoiding soft tissue complications. Another is avoiding those fractures that we know are going to lead to poor outcomes, and that includes those with major deformity. And once you've done enough open treatments to those complex fractures, you can understand ways to reduce the soft tissue intervention, as Dr. Prabhakar was just talking about. So reason number 1 to fix calcaneus fractures is that acute displacement can lead to soft tissue compromise. And this is a classic example of a tongue-type fracture that's pushed posteriorly. The skin is under pressure. There's very little soft tissue padding there, and within a day or 2, you can develop a full thickness lesion there. This is a patient who presented the morning that I was intending to leave for the academy meeting one year, and he was just injured the day before, already had a full thickness lesion, and we popped him back together before going to the academy, and he still had this lesion. Imagine if we had waited till the meeting was over. So these posterior tongues are particularly prone to this disorder, and these are managed acutely by hyperplanar flexing the foot in the ER to take that pressure off the skin posteriorly and then getting them reduced as quickly as you can. This was outlined by Mike Gardner, who was one of our trauma fellows a decade ago, who's gone on to write maybe 150 other papers since then. Reason number two is that calcaneus fractures have a poor outcome from closed treatment. Not all, but many. There's only one standard natural history trial published, and that was out of the Mayo Clinic, with a small number of patients using outdated measurement tools. The 27 patients were followed between 2 and 10 years, and 5 had excellent or good scores. Basically, 40% of the patients did okay, did reasonably well and returned to function. That's not a very good number. Half of them had moderate to severe pain. 6 were considered disabled from work, and 6 of the 6 had a discernible limp. And these are the classic problems that you see. It's a wide heel with an irregular plantar surface. You can see that there is bone under the fibula, just looking at it clinically. The subfibular impingement is probably the #1 cause that people can't walk well after a calcaneus fracture. And there's a horizontal talus, as Dr. Prabhakar just pointed out, that does not allow you to dorsiflex the ankle. This is a classic trans-Chopart fracture dislocation as described by Dr. Bellabarba back in his trauma days. It was a typical scenario where the neurosurgeon said, don't bother fixing anything because the patient's not ever going to wake up. And then 6 months later, he wanders into the orthopedic office with a significant deformity. So we manually reduced and pinned the talonavicular joint and left the calcaneus alone. And at 6 months, he was still on crutches because he had so much pain laterally under his fibula that he couldn't walk. And this is the area where the bone impinges. And if you look at a CT scan, I'm not sure if you can see my cursor, but draw your eye down the fibula and see what's awaiting it there. There's no place for the perineals when this person tries to walk. The perineals are crushed or amputated at that point between the bone. And with the vertical talus, horizontal talus, there's very room for the talus to dorsiflex. So these require pretty complicated salvage with a loss of the subtalar joint, and they have large needs for bone graft. Although they can be salvaged, it's really much more challenging than salvaging a nicely reduced fracture, as Dr. Prabhakar just referenced. The third reason is that there are data gaps in all of these studies that leave out important parts of the discussion. First, you can't take a surgeon and turn them into a placebo pill, so you can't really standardize surgical experience or surgical expertise. And we know that high volume leads to lower complication rates. So none of these clinical trials that were reported had high volume centers involved, or at least not for a very large number of the patients involved. So all of these found no difference on the surface, but if you look closely at their data, you find a number of challenges. This was a landmark trial 20 years ago. They started it around the time that HIPAA came in the US, so we couldn't easily do a trial like this on our side of the border. And it was really a landmark trial, very well conceived for its time, but it had shortcomings. So they enrolled 512 patients over 10 centers, but almost 90% of them were in one center. The other 9 centers had the other 10%. They enrolled 427 patients, and it had 309 of those assessed, which is very good for trauma. Anything over 50% is pretty good for follow-up a trauma patient. But they used a proprietary visual analog scale that they didn't describe, and they used an SF-36, which is a psychometrically balanced instrument to look at general health, not health about a specific impacted disorder. If you're measuring everything, each thing has less impact. So this is their cohort study analysis to see how they broke down. They ended up with 148 patients completed the trial in the non-operative limb and 161 in the operative limb. And while they found overall no difference in the two groups, they had a number of hard to interpret findings where there were difference. First of all, when the workers' compensation patients were removed, there was a difference between the operative and non-operative group. So that may have skewed it. These other findings that men under 50 did better, but not those over 50, women did better than men. Bowler's angle that was compromised, but not really reversed, did better, but not the high and not the low. Those are all quite difficult to understand. And most importantly, that the closed treatment group was 6 times more likely to have an arthrodesis in the postoperative period of the trial of study. So when you have findings that are all over the place, and a big finding like this that's not consistent with the overall findings, you have to wonder if the right questions were being asked that would allow you to detect the difference between the two groups. And it's likely that there wasn't the ability to detect small differences in this trial. So although there wasn't a difference in the SF-36, there's a lot of components in that SF-36, including mental health. So the big number is not as easy to understand as the individual number. And the visual analog scale wasn't even described. So it's hard to really take too much of this to make this for decision-making purposes. The Swedish trial, Per-Henrik Agren, started when he was a trainee. He was an MD PhD student, and then he left academics, went into private practice and forgot about it for a decade, then came back and wanted to finish his PhD. So he called up all those patients. And it was a small trial with 82 patients, and they were enrolled from 94 to 98, and included everybody with all deformities as long as there was more than 2 millimeters of displacement in the joint. And they were followed independently. The surgeons didn't get a role in assessing them, which is an important thing. The primary outcome measure, again, was a pain score and an SF-36, but they had a secondary measure, the AOFAS score, also a very flawed score, and the Olerud-Bolander score, which was validated for ankle fractures. So they had remarkable follow-up, something we could never do in an American trauma center. They had 76 out of the 88 enrollees follow up at an average of 8 to 12 years. And at a year, the primary and secondary outcome measures didn't differ between the two treatment groups. And at 8 to 12 years, there was a trend toward better scores on the patient-recorded primary score and the physical component of the SF-36. But as most statisticians will tell you, a trend is not meaningful. But there was post-traumatic reduction, the reduction in post-traumatic arthritis in the operative group, and a substantial one. So the most recent trial that Pooja just talked about is the British trial, in which they enroll all of the UK, 27 centers, into randomized trial. And this was a pragmatic trial with an ethical basis. In other words, they removed all of the patients who they thought would do poorly if not treated better. They enrolled, they screened 2,000 patients and ended up only finding 351 of them eligible. And again, this got rid of all the patients who we know have troublesome fracture patterns, subfibular bone, varus, and valgus of significance or dislocation. They also excluded those that were highly common. So all fractures that you think would do better if they were treated open. So it ended up with 7.5% of the patients during the study period, with 69 operative and 74 non-operative, and followed them for 2 years. Found no difference in the Kerr-Atkins score, which was a specific score for calcaneus fractures, and no difference in pain and no difference in function. And secondary outcomes were available in 75%. So this is a strong trial that tells us if you eliminate the ones that have severe fracture characteristics, you probably aren't getting a lot of benefit out of surgical management. And a Cochrane analysis of all those studies basically found that the methodologic flaws were high and the risk of bias was strong. So we don't have good data, but I think there is convincing data that closed treatment is a valid option for calcaneus fractures. This is a patient of mine, a young woman who was a tech worker who played a lot of soccer after hours. And these were her playing films. I told her that we could treat this closed, and I gave her the statistics at the time, but I wasn't terribly comfortable treating it closed because of the amount of lateral displacement. You see a full centimeter of lateral displacement of that tuber. So I was reluctant, but she was insistent that we treat it closed. This is the CT scan showing that there actually is some room under that fibula. There's no direct impingement. Even with weight bearing, there's going to be a little bit of room. And the joint itself wasn't terribly displaced. It was just a lot of displacement of the tuber, which was quite lateral. So I saw her on my schedule 17 months later. I thought, oh, now I'm going to really regret treating this non-operatively, but she came in because she sprained her ankle playing soccer, wanted to make sure she hadn't done anything to harm herself. So she was back to full function at a high recreational level in spite of us not correcting the fracture. And you can see a pretty well preserved middle facet and posterior facet on those. So all well and good. If the surgeon can predict the ones that are going to do badly and treat those open and look at the ones that are not going to do badly and treat those closed, then we can just divide them that way. It sounds pretty fantastic, pretty unreasonable that we could do that. So we put together a study where we surveyed 100 patients with isolated calcaneus fracture with the short form MFA, a very valid instrument for measuring outcome in trauma. And about half of those responded to the survey. So we took their x-rays in a different group. So the surgeons did not know what the surveys showed. And we looked at the 50 x-rays, and Dr. Bernershka and I, a resident and 2 fellows, looked at those films and rated them. We basically said, is that going to do well or do poorly? And then we applied 3 different CT-based CT-based rating systems to try to use any system that would help us predict poor outcome. And then the 3 CT-based systems, including the Tampa and the Atkins scale. We also counted the number of posterior facet fragments, the number of anterior facet fragments. And none of the CT classifications predicted outcome. The best predictor was the surgeon saying, that looks awful, it's not going to do well. And the second most useful was counting the number of anterior process fractures, which, as you know, is not part of the Tampa classification at all. So we can somewhat predict it if you're a relatively senior surgeon and you've seen a lot, and that can help guide you a little bit. But we also know that outcome is related to volume. The more procedures you do, the lower the number of adverse events. So this is probably applicable only in a high volume system. So Dr. Prabhakar went over the fracture anatomy. The primary fracture line rarely lives on itself, and there's very often a fracture line that splits the middle facet and moves that constant fragment into an inconstant position. And the parts of the posterior facet are usually split in 2 by the tuber, which has been driven up. So pulling that tuber back down out of the way so you can get those pieces in place is a key element to being able to use the smaller incision techniques. The extensile approach, you have to wait and wait and wait sometimes, and it does create a big flap, and it does have a relatively high rate of delayed wound healing closures. But that flap was a modification created by Dr. Bernershka and independently created by Nate Gould at the University of Vermont. That was an antidote to the Palmer approach that was being used in those days, which is very similar to the sinus tarsi approach being used now. But by lowering the horizontal part of that flap, you can see in there and find that wedged piece of posterior tuber that was dividing the halves of the posterior facet. So until you pull that tuber back down, and we created these arrows in the original document to show the 3 directions that you have to move that tuber. And the relative thickness of those arrows is intended to show the amount of that change. It's primarily pulling it down and away from the talus, and then rotating it out of varus, and then medializing it. And once you do that, then putting the anterior process together is easy, and the posterior facet is the easiest of all. The patient is positioned laterally, whether it's open or closed treatment, lateral with the heel at the corner, so you can obtain an intraoperative axial view and an intraoperative lateral view with ease by rotating the C-arm. The sequence here is a little bit complicated. So if you look at those CTs, the primary fracture line is split in two, and the constant fragment is displaced, and the separation between the middle and anterior facets is clear. So the sequence is to go anteriorly, anteromedially, medial wall, and posteriorly. And you can put that together in that sequence. And it's basically ignoring the classification system and putting together the anterior part first and getting that primary fracture line pulled down. So this is a comminuted but not horribly reversed Bowler's angle patient. You can see where the red arrow is, that there's a split between the two halves of the posterior facet. And there's substantial amount of comminution in the middle and anterior and posterior facets. So we pulled that tuber down, lined up the medial wall to get it out of the way, and assembled the various components. Here's a post-reduction film, and here's the patient 6 months later at end of care. So you can get all those pieces back together. The screw represents the poor man's equivalent of a locking plate by running that screw along the medial wall. But the best part of open treatment is that it gives you insights into the fracture anatomy so that you can use a smaller incision as time goes on. I think I can get these to run. This was a patient we thought might be too comminuted for a small incision technique. You can see the anterior part of the calcaneus is shortened, and this sustentacular piece is displaced medially. And if you look at the axial view, you can see the split in the posterior facet with tuber wedged in between them. Not advancing here, let's see. So here's the technique for the small incision. You can see a lot of comminution in the anterior facet. But you put Schanz pin put into the tuber, can pull it plantarly, can get it out of varus. A K-wire along that medial wall can hold that position. And then an instrument used to push up on the posterior facet fragment, templating it against the bottom of the talus and the other half of the talus. And then wires for the cannulated screws are inserted. And here's the patient at 6 months. That's what the incisions look like. Here's the patient at 6 weeks, very early in return when starting to weight bear. You can see it's a little bit quicker than using an extensile approach and waiting for that incision to work. But what this technique really is converting a highly comminuted fracture that would need open treatment into one that could be treated essentially closed. So in summary, some calcaneus fractures don't do well if left alone, but 2 of 3 prospective trials have shown subtalar arthritis rates a little bit lower in the ORF group. And if you take the bad deformity types out, closed management is a viable alternative to open treatment, particularly in low volume institutions. In the absence of a lot of lateral displacement or horizontal talus or skin at risk, closed treatment is a viable option. And the experience of the surgeon, the age of the patient, the soft tissues, the activities needed all come into the decision-making process. And open treatment leads to a better understanding of the fracture anatomy. So if you need to move to a smaller incision, you have the skill set to do it. So I think Dr. Prabhakar has a couple of cases to share.
Thanks, Dr. Sangeorzan. Actually, the 2 cases that we had are actually the same ones that you just went over. So I think we can move on to questions from anyone if we have any.
I have just more of a logistical question, maybe more geared towards Dr. Sangeorzan than Dr. Prabhakar. But you mentioned how some of the higher level data that we have or evidence that we have suggests, again, if you don't look at the nuances, that non-operative treatment would be more appropriate for calcaneal fractures. And obviously this is trauma, it's a little different, but in the elective spine world, what we've seen is when that type of evidence exists, all of a sudden the insurance companies decide that they know better than we do in terms of what should be treated and how, operatively versus non-operatively. Is that something that you have encountered or that you are concerned about being a problem in this type of scenario?
I think it's a great question. And I have personally faced that, and the University of Washington is in a unique perspective. I actually almost made that comment at the beginning of my talk, that 3 level 1 trials should normally say the insurance company is no longer going to pay. But I think the Damien Griffith trial, which was the best of the prospective trials, gives you evidence to support open management. And the University of Washington is one of 12 universities that help with CMS and Anthem. Together, those groups create medical policy. And back in 2009, they had created a policy that said they would no longer pay for ankle replacements. So this was broadly applied to all the Blue Cross Blue Shield payers in the US. And they sent out that policy for pre-review to the 12 data centers. And the dean's office asked us to respond to it. And we had data at that time from an observational trial that we had completed at the VA. And we were able to point out to those epidemiologists making the policy that it was missing a whole lot of important data, and all the data they were putting their policy based on was significantly flawed, and they behaved very reasonably and looked at the data we showed them and reversed the policy. They were, at the time they said they were reversing it, they would reassess in 3 years, but either they didn't reassess in 3 years or they looked at it strong enough to reverse it. So the strongest message there is that you young folks who are entering into practice or entering into a university group, make sure that your electronic medical record has pre-op data collection for every patient. It should have a pain score at the least. It should have an average pain score, a worst pain score, and some measure of function in that group, whether it's the KOOS or the HIP score or the FAM or MFA. Every new patient that you're going to treat surgically should have that data in your medical record. So if your policy folks in your area say there's no evidence that you're making people better, you can check the data, and maybe they'll be right, and maybe you'll have data to refute them. But it's a fairly critical question. We have to show our value, and a lot of the things we do don't have value. Famously, the randomized knee scope trial in Texas showed that the placebo group patients got as much improvement as the actual arthroscopic debridement patients. And most strange in that trial was when the trial was unmasked, the patients came back to repeat the treatment, were told that they had placebo, they wanted it again. They wanted the placebo again because they got better. So having data that you can use to inform the policymakers, it takes some of the sting out of having an electronic medical record. We all spent an extra 10 hours a week doing dumb things on the electronic medical record that don't help our patients, and that's one that might. So I know that's a long-winded answer.
Bruce, I see that this information, the data is really nuanced. My question is there any way, even at our high volume center, to tell the difference between anatomic reduction and just pretty darn good reduction and at least it's reduced? Do we have any information about that?
So the Buckley trial did look at those within 2 millimeters and not. Actually, a predecessor trial to that group. They did show better outcome. It wasn't well defined. And the Ogren trial did show that if they were reduced, they did better. But they're pretty poor quality assessments. They're not very accurate, and they were biased. The surgeons were the ones making the measurements. To make that data better, it would have been nice to have a trained radiologist looking at them or someone who wasn't involved in the trial. But I think my bias, and I'm sure that I have partners who disagree, was that the Griffin trial did show you don't have to get them perfect. If you can do something that gets them close and gets those bad factors out and treat them without a big incision, you're probably doing them a favor. I do think in a high volume center, that equation changes because every one of us has seen what Steve calls OIFs, open internal fixation, where they opened it and put a plate on, but they didn't come anywhere near reducing it. That doesn't happen here. It doesn't happen in our institution. So we're going to have a different skew on that data. But I do think that's troublesome. Like I said, you can't create a placebo surgeon, that you can't make the surgeons all equal. What you can do is make sure that the surgeons all have the same standard care and the same level of experience, you could say they need to have treated 30 calcaneus fractures open. Like we did in our ankle arthroplasty trial, surgeons in that group had to do both fusions and replacements, and they had to have 5 years of experience doing both, and they had to have a minimum of 10 supervised total ankles. So you can do little things, but you can't really create a little placebo pill.
Because what follows from the data is that it seems close treatment is appropriate for most fractures, many fractures. And then there are the god-awful ones, the subfibular impingement, the this, that, and the other thing. So if you just convert those to not god-awful, just bad, those wouldn't have been treated in the first place. So it isn't an all or nothing. It can't be an all or nothing. It has to be terrible is terrible, make terrible good, or make terrible less terrible, and they should do fine.
I think we'll create a new outcome measure called the MOSCA score, which terrible, terrible, less than terrible, bad.
Well, god-awful is the top one, god-awful.
Yeah, I think in clinical trials, orthopedic surgery is a very difficult field to do prospective randomized trials. The patients are not very likely to randomize. In the UK, patients are very easy to randomize. They were told, you have this fracture, we'd like to randomize you. The patients there don't have the New York Times printing articles about how awful doctors are every day. They trust their health system. They're willing to randomize. So I think they have some advantages. We could not recreate that trial. Damien Griffith got a lot of grief from his fracture colleagues about that trial, but I think they did a good job of trying to manage it ethically and trying to randomize it in an appropriate way. But again, the surgeons contributed between 2 and 6 fractures each. These are not high volume institutions.
What do you think, Bruce, would constitute, like at what point do you feel the number of cases that you had to do to get to a point where you were sort of beyond what you would consider a standard learning curve?
I think that's a tough question. In the business world, they all say 10,000 hours. So
Yeah.
if you take 10 hours per fracture, then you only have to do 1,000 of them. Realistically, if you have treated a lot of trauma, if you're treating pilons and you're treating plateaus and you're treating pelvises, your learning curve is going to be a lot shorter. But I think I've thrown out the number 30 in the past. I personally thought after 30 of them, I had a good idea of what I was doing. But honestly, at 100, I would find one that I said, I have no idea what I'm doing here. So I think they're complicated. You know, revision hips, revision ACLs. There are some things we do that are very technical and take a lot of insight, but CTs help. You know, we've done a lot of CTs and training. Obviously, my bias is that people fixing calcaneus fractures should be at a center where there's a high volume. There's good data to support that comment. And I think if you can get 30 of them done during your training period, you're probably at least launched to the point where you're not going to create these disasters that we see on a regular basis. And I don't know if Dr. Banershka's on, he might have a different number to share. Or maybe Dr. Githens, he's newer to the game, but does quite a few.
Doesn't look like it. Any other questions? Any questions for Dr. Prabhakar?
Just want to comment that Dr. Prabhakar did a very nice job of summarizing 40 years of literature with only 2.5 weeks notice.
No, this was really an outstanding presentation. I haven't thought about calcaneal fractures all that much in the last few years, and I really felt like it was a very educational summary and an update of where things are now. And I wouldn't say that much different than they were, let's say, 10 years ago, except that it sounds like, at least from the perspective that you gave, that there's maybe more of an emphasis towards a less extensile approach to some of these injuries.
Yes, I think there's a very, very strong trend to using the sinus tarsi approach. And interestingly, that's quite like the Palmer approach that we used back in the late 80s here and abandoned in favor of the extensile approach for the reasons I outlined. But I think what's ironic to me is that I was worried when I took my boards that the fact that I was treating them open was going to keep me from passing my boards. And then 20 years later, in spite of no high-level evidence, I've now defended 2 orthopedic surgeons, who are sued for not doing open treatment. So it's a funny world out there. We could use better evidence for everything we do.
All right, well, thanks again. Again, with such short notice, Dr. Sangeorzan and Prabhakar, and I guess we'll give you about 15 minutes of your time back. Have a good day, everyone.
Thank you, everyone.